Hi, everybody. Welcome to week 3 of Health Systems. So I just wanted to send a quick check-in to reinforce what I'm looking for in the discussion posts. So everybody should have already seen feedback for discussion 1, and I am currently working through discussion posts for discussion number 2. So one of the items that I saw that was consistent in discussion post number 1, which I've seen in other semesters as well, and I almost intentionally do this because I want to kind of raise the point. So throughout the course, a lot of the content that we're going to cover is fairly straightforward. We have people in this class with decades of healthcare experience, and we've got people who are not only not new to the industry, but actually haven't worked in it. So this is really a level setting course and making sure that we're all on the same page with the major facets of how healthcare delivery works in the US. So some of the content is going to be fairly straightforward. But what I'm looking for is with every discussion and every research project we do, and some of the more quantitative work that we're going to be doing in the second half of the semester, is I want you to really think about what is a specific data point or a fact or an aspect of care delivery that's really not working well or is an area of opportunity. How do we think about the individuals that are impacted most? What does that population look like? What are the demographics and the predisposing and enabling factors that really set the stage for the health status of that particular population? Now, in discussion 1, we were looking at the CHIRS health status indicators by county and really doing some comparisons with surrounding counties and New York State as a whole. Now, I also threw in a question at the end saying, okay, well, in this scenario, with this specific indicator that you're looking at for your community, what really makes sense of a view of social justice, where we're looking at healthcare as a right, or market justice, where we're looking at it as a commodity that can be bought or sold. Now, this is not a politically driven question, and I will never ask that in this course. And I want you to be really careful to not just say, oh, this one aspect is obviously better off, and in which case many of you said, well, social justice obviously is going to help this because we need to be thinking about how we can provide this support to those that need it, right? And in many cases, we're looking at disenfranchised populations that are being impacted most often. I want you to think really, really critically about this. And as we work through the content every week, I want you to get even more nuanced and kind of critical of how you're thinking about these different aspects of healthcare delivery. So as we saw in the past week, and as we're going to see this week in chapter 3, when we focus on how we're financing healthcare delivery, it's complicated. It's convoluted, it's messy, and it's really hard to tell how much you're paying for services and the quality that you're receiving. So in a free market society, if we look at any other industry, you typically have price transparency. You know how much whatever it is you're going to buy is. You can compare between different providers, and you can also look at some quality feedback. Amazon is a really great way to just think very basically about how a free market works, right? You're able to go in, you're able to compare price points of different companies for whatever product you're looking to buy. And you can also gauge, like, okay, where are these companies located? Is there anything that I can gauge based on their promotional materials about what the quality might look like? If there's misspellings and if there are bad reviews, that's an indicator that maybe you're going to want to pay slightly more for better quality for whatever it is you're looking for. It is baffling that that does not exist in healthcare. Our lives literally depend on it, and we don't have clear information on how much a service costs. We don't know how much, if we're going to go, let's say, get an x-ray, or if we have maybe a chronic condition that we're working on resolving. We don't know how much each interaction with healthcare delivery is going to cost, let alone the lifetime of care that we're going to need to try to work through some of these issues. And we really don't have a lot of information on quality either. In the past few years, there's been a push to try to increase some transparency, both in pricing and in quality. We can see CMS has what is called the 5-star hospital ratings now, and they take some key metrics that are required to be reported by any hospital or health system that receives Medicare or Medicaid payment. And they're going to look at, healthcare delivery. So, for example, if a patient comes into the emergency room, how quickly are they receiving care? We can look at different things like patient satisfaction. We can look at hospital-acquired infections. And all of these metrics are kind of bundled together for one 5-star rating for hospitals. Now, that is intended to give patients and their family members some idea of what we can expect with respect to quality and make some comparisons before we decide where to pursue care. So when I ask questions about social or market justice, I am not looking for a quick, this one's good, this one's bad. It is not that simple. And especially in the US, when we have this kind of quasi free market system where you really don't have insight into how much something costs or what the associated quality is. In some cases, market factors, bringing that transparency in will help to, if we're looking at cost transparency, that will automatically kind of create some competition where then, we're also going to be looking more acutely at what is the quality you're getting at these different providers. And that helps, patients and their families, again, make more informed choices, and it can help improve the overall delivery of care within the US. Now, that's not to say that those market factors are always the way to go. In some cases, when you're looking at specific demographics and looking at individuals with a certain set of predisposing or enabling factors, those market factors aren't really going to play a role. They need some support. They need, more broad access to care, close to home. And so that's what I'm really looking for you to get at is, as we move forward, our health system is so complicated. And that's not to say that it's not in other countries as well. This week, there's a great breakdown or an image in chapter 8 that kind of goes through, again, how do we think about how healthcare delivery looks in different countries. And we saw this last week again as well. And if we look at Germany, we've got sick funds. And it's not as simple to say, okay, well, everybody has access to these sick funds, which they do, but there are 124 of them to choose from. So in many cases, it's very kind of complicated to kind of work through and decide which sick fund you're going to use, just as it is with the exchanges here in the US for health insurance. So there are some similarities there. If we look at the NHS in the UK, that is a scenario where the government is both the insurer and the payer and the provider of care. The NHS is run by the government, whereas in Germany there are private providers. And then in Canada, it's kind of a combination of both, where the government is providing, again, some insurance, but the providers are often independent or private. And in the US, we are just kind of all over the board, both with respect to the providers. We have government run health centers like the VA. Many are private, some for-profit, some non-for-profit, which we talked a little bit about last week as well. And then as we look at who's paying for this care, it can be a combination of, if we're looking at Medicare and Medicaid, it can be the government, it can be completely self-pay, although we're trying to move away from that with the ACA. And it can be employee-sponsored health insurance, which really is another version of self-funding. But above all, it creates a system that is overly complicated, and it creates a situation where we, again, don't have the transparency to make really critical decisions about our care, where we're receiving it, the quality that we can expect. And that's what we need to move towards. So throughout the course of the semester, as we continue to have these discussions about opportunities for improvement, I really want you to think critically about, okay, what might this look like in Germany or Canada or the UK? How does it differ from the kind of complicated system that we have in the US? And as we start to think about interventions that might make sense, are some market driven? Are there digital transformation trends? I know a lot of you were talking about mental health. There are a lot of new mental health platforms that are coming out that can not only connect us to our primary care providers and kind of augment that with additional services. How are those being paid for? How can we, through those new mechanisms, include more cost transparency and quality transparency to help us make better decisions about our care? So again, long story short, I'm looking for you to get in the nuance. I want you to try to use as many supporting resources as you can to really think through it. I am never going to ask you a politically motivated question, and I really want you to kind of check, when you're responding, thinking about, okay, this is good or this is bad. It is hardly ever the case where something is that clear and cut. It really is going to require you to dig into the details and understand in what circumstances might this approach make sense, and in what circumstances could it be problematic. And just to finish up, so this week we're going to also be presenting the concept of moral hazard as it pertains to healthcare insurance. Now, there's only been one kind of clinical randomized trial, the RAND study, It's the one everybody cites. And while I think some individuals will be quick to jump to conclusions from the study that was done decades ago, really, as we dig into the details of it a little bit more, it really demonstrates that it's nuanced, right? That this concept of moral hazard may make sense and may apply to certain groups and not to others. So again, I want you to try to continue to think about, as we think about healthcare reform, or as we even just think about specific opportunities in our communities or in the health systems in which we work, how can we think about all of these different factors of healthcare delivery in the US and tweak them and modify them to, again, try to get to that cost transparency, quality transparency, and access? How are we going to provide the people that need the access, the ability to receive care when they need it? That is the triple aim. And we expand it to the quadruple aim when we pull in that regardless of how we're delivering care, we want to make sure that our providers are in a position where they're able to do their jobs, they feel supported in doing that, because when they do feel supported and they feel like they're able to have meaningful roles in improving the lives of the patients that they serve, we see that patient outcomes and patient satisfaction is only going to get better. So again, that's a lot. Stay in the details and in the nuance, stay open to it. Try to be critical of when certain interventions may apply, when they may be problematic. Don't feel like you need to jump to conclusions. I certainly won't expect that of you. But just try to think thoughtfully about the topic each week. And I look forward to continuing to see your work throughout the semester. As always, if you have any questions, please don't hesitate to reach out.